Good afternoon and welcome to United TV again. Today, on our Bariatric Friday session, we are going to discuss resolution of comorbidities. With that, welcome to the studio. Now, I said, right?
Thank you, Kemal.
How are you doing?
Great. It's wonderful to be back here for Bariatric Friday.
Thank you, and it's always good to see you, but it's even better to see you in person. Thank you. So we are going to discuss the resolution of comorbidities, as I said. Comorbidity is other illnesses that comes with the main illness. So someone who has diabetes, if they have hypertension would be a comorbidity to diabetes. If they have morbid obesity, may be the comorbidity for diabetes. When you're managing diabetes, you would look into the other issues and how they are contributing. So in our case, we believe that many of these problems, the origin of those problems is morbid obesity. So therefore, we need to actually look at it not in a reverse, from the reverse side of it, but maybe from the correct side of the equation. The origin is the morbid obesity. So diabetes is the results of maybe morbid obesity, and hypertension is results of morbid obesity. So instead of trying to fight those individually, if we are able to take the morbid obesity out of the equation, then we may not need to treat diabetes, hypertension, sleep apnea, certain heart conditions, and cancer, like not getting ready for it, but going through the cancer less severe stage, and joint pain, and many others. So now, Dr. Ergau, you are going to help us.
Absolutely. You've nailed it, Kemal. In other words, the root cause is the obesity. In fact, rather than calling these comorbidities, we should call them complications. Really, because sometimes comorbidity implies something that you find alongside that problem, right? Oh, you have heart disease, and then your comorbidity, diabetes or kidney disease, right? In this case, we're talking about direct complications of morbid obesity. So one of the greatest revelations for healthcare providers with the advent of bariatric surgery, which has proven itself to be the most effective treatment we have for severe obesity, is that the weight loss in itself is actually the outside outcome that is obvious for anybody to see. But the really very important outcome of bariatric surgery is the resolution of those dangerous comorbidities, or resolution of those dangerous complications of obesity itself. Very often when we see patients coming to see us in the office with body mass indices greater than 50, which means that person is 120, 150, 180 pounds over their ideal body weight, very often they will come with a history of other diseases that have developed over time as well. Very commonly, they will have type 2 diabetes, for which they may be on multiple medications with difficulty in controlling their blood sugar. Often, they will be treated for high blood pressure, again, by more than one medication. Very often, they will have sleep apnea, and they will sleep at night with a CPAP mask, without which they would not be able to get a good night's rest. Very often, they would have high cholesterol. Very often, they will have had some type of event of cardiac disease. Right? So these are serious, very serious illnesses that are complications of morbid obesity. And when we are able to tackle morbid obesity with bariatric surgery, we see, as the title of this program implies, the resolution of those complications is right. And the numbers in terms of the percentage of people who actually free from themselves from these complications is very high. With diabetes, it could be over 90% of people with type 2 diabetes getting either complete resolution of the type 2 diabetes or much better control of their blood sugar. The same with high blood pressure, it could be up to 75% of people. With sleep apnea, it could be even close to 100% of people, 95% or plus. Same with people who have high cholesterol, as well as the risk of cardiovascular disease. But then the other most important complication of morbid obesity is early death, right? People not really living to their expected length of life, right? So that is really the ultimate complication of obesity, and we are able to prevent that if people are able to lose weight effectively. So really the primary driver of bariatric surgery is really targeting those illnesses that can lead to an early death. Type 2 diabetes, high blood pressure, sleep apnea, high cholesterol, heart diseases, and there is growing research showing that many cancers actually happen to be more common if people have morbid obesity as well. And reduction of weight with bariatric surgery actually leads to a reduced risk of those cancers as well. So the implications for the health of our society are huge when we really are able to tackle morbid obesity effectively.
I want to better understand the prevention for cancer being heavy, I guess, not having morbid obesity and cancer. If you can explain that to us, because cancer is still one of the biggest problems in the healthcare as a disease in this field. And it's costly, but also it's costly not just financially, but it's costly because not everyone is able to survive. With morbid obesity and the impact on cancer, let's better understand that a little bit.
Absolutely. So this is an evolving field where a number of epidemiological studies have demonstrated that the higher the body mass index, the higher the risk of developing certain cancers, whether it's breast cancer, whether it's uterine cancer, whether it's colon cancer. It has been seen.
Mhm.
But the other thing that has been seen and studies have shown also is that when people undergo bariatric surgery and there is dramatic weight loss, the risk of developing cancer also goes down, right? So we know that obesity has something to do with the development of cancer as well. The actual mechanisms are more theories right now than having been proven. We know that obesity drives constant inflammation throughout the body, and constant inflammation may be related to the development of some cancers as well. So although we don't know exactly what the mechanisms are that are driving the development of cancers in the setting of obesity, we have seen direct evidence that weight itself is a major driver of the risk of developing cancer, and reduction of weight also leads to a reduced risk of many of these cancers as well. For instance, one of the very commonly seen phenomenon right now is that the age at which people are developing colon cancer is getting lower and lower, meaning that younger and younger people are developing colon cancer, who used to be associated with an age which was much more advanced before, right? But now we know that there is a lot more obesity among younger people as well. And obesity by itself, that may be the main driver. It is huge, it is huge. This is really the implications of understanding obesity and the complications that come with it. And really focusing on reducing obesity will help to decrease many illnesses that are frankly life-threatening.
So the other part is we discussed in the first session of this cycle is the different bariatric surgery types. So does that make any difference, even if weight loss may be the same, but having gastric bypass versus gastric sleeve or band, like in terms of resolutions, does that have any impact on the outcome?
So, in general, any intervention that will lead to significant weight loss will be mirrored by a significant decrease in the complications of obesity, or all those illnesses that we speak. But for something like type 2 diabetes, there seems to be an advantage of procedures like gastric bypass, or even to a greater extent, duodenal switch. What is common about gastric bypass and duodenal switch, Kemal, is that there is rerouting of the intestine. And that rerouting of the intestine by itself seems to affect the resolution of type 2 diabetes much more quickly and perhaps even more significantly when compared to other procedures where there is no rerouting of fetus. So if you take somebody, for instance, who has type 2 diabetes, whether they have gastric bypass or the gastric sleeve, they will see an improvement in type 2 diabetes, right? But very often with gastric bypass, you may see an immediate improvement of diabetes even before the weight loss occurs. One of the greatest observations of the teachers that taught our generation of bariatric surgeons, and I'm talking people who really started this over 30 years ago, is that they saw patients coming to the hospital to have gastric bypass, which was the most common operation. And I'm talking about 35, 40 years ago. These patients would be patients that have horrible diabetes. They would be on insulin. And those were the days when if you were to get an operation, you would be in the hospital 2-3 days before, right? You were admitted 2-3 days before, and then you would be in hospital, obviously, for days, if not longer, after the operation as well. What they have observed is that these patients would come to hospital 2 days before their surgery, and when they are being prepared for surgery, they would be on insulin because the insulin is one of their medications that they came to the hospital with, right? So the doctor would write an order for them to have insulin as well. They've been having insulin until the day of their surgery, and then they have surgery, and then they go to the floor, and the doctors would write, okay, for this level of blood sugar, I want you to give them this much insulin. For this level of blood sugar, I want you to increase the insulin so much. And they would give them what's called a sliding scale, which means that the nurses would check the blood sugar, and according to where the blood sugar is, they would give insulin. But guess what happened? For many of these patients, as early as the first night after surgery, their blood sugar would normalize with no insulin at all. Now they haven't lost an ounce of weight yet from the surgery, and yet there is improvement in diabetes. So gastric bypass and procedures like gastric bypass, where there is really rerouting of the intestine, seem to have a much more profound effect on type 2 diabetes compared to other procedures, where the resolution of type 2 diabetes has to wait for significant weight loss. Now, this phenomenon of improvement of type 2 diabetes immediately after surgery does not occur with all patients, but it occurs in a good percentage of patients, really, to the extent that there are places in the world where doctors are recommending procedure like gastric bypass for patients who have type 2 diabetes, and they may just be marginally overweight, body mass index of 27, 28, right? So there is really a profound improvement in what's called the metabolic profile of people when bariatric surgery is performed.
Good afternoon and welcome to United TV. It's our Bariatric Friday session with Dr. Ergau. Dr. Ergau, how are you doing today?
I'm doing great, Kemal. I'm very happy to be in this wonderful studio.
If we can actually just walk the patients through for the day of the surgery and what do they expect before the surgery and the day of the surgery and the right after.
Absolutely, absolutely. So we can actually look a little bit into the immediate before surgery time frame, right? Patients will be on a special diet that we call Robert diet, but it's actually the New Direction diet from the Robert Corporation. And it's a meal replacement diet that we want patients to be on for about 2 weeks, sometimes 3 before surgery, for them to be able to reduce what's called visceral fat. And that is the fat in the abdomen, primarily in the solid organ like the liver. Because when we are heavy, the liver tends to be very large and very dense, and the liver covers the stomach, which is the main target of our procedure for surgery. And for us to be able to move the liver very easily without too much challenge during the surgery, we place patients on this diet, which will shrink and make the liver a lot softer and makes the surgery much less challenging. So patients will be on that diet, and they will be towards the end of that diet at the time that they are ready for the surgery. They will be obviously receiving instructions from our office as well as from the surgery center about what to do the night before surgery, the day before surgery, for instance. And one of the important points will be what to do with their medications. And there are certain medications we want them to continue taking, and there will be some other medications that we want them to hold off. And these discussions obviously are individual. There are certain medications actually that we want the patients to take even before they come to the surgery center. One of those medications is, for instance, is Tylenol. Although patients are instructed not to have anything to eat or drink after midnight before the day of surgery, we want them to typically use a sip of water to take medications that are necessary. And one of those medications will be extra strength Tylenol. Now, people are used to think of pain medications to be taken after surgery, not before surgery. But we do have this special protocol in our surgery center where we are actually gearing the patients, preparing the patient to have less discomfort by priming their body, their system really to be much less uncomfortable after surgery. And one of the ways to do that is to prepare them by having them take pain medication like Tylenol before the surgery. And we ask them to do that before actually they leave home to come to the surgeries. At the surgery center, obviously, they will be received by our nurses while they will be doing the preparation for the actual surgery. Now, the surgery itself, even for the more complex surgeries like gastric bypass, takes typically about an hour and 15 minutes, an hour and a half. This is the actual surgery. But there will be a preparation period before then where the patients will be prepared by the nurses and they will be meeting the anesthesia staff and then, of course, the surgeons as well. That preparation typically entails them taking some additional medication, like antibiotics, for instance. Antibiotics are an important component of the medication we give patients before surgery because that minimizes the risk of infections, right? And another medication that they will be given is a blood thinning medication, Lovenox. And that medication is very, very important because it's one of the methods we utilize to minimize the risk of blood clots during surgery. So all these preparations, as I'm talking, obviously, are geared towards really preventing problems, right? Staying ahead of the issues. And typically when we talk about the risks of the surgery, we tell our patients that, you cannot bring risks of surgery to zero, but you can minimize them to a great deal by taking preventative measures. And in our program, we focus on prevention, and we've been really successful in minimizing complications by taking these preventative measures, whether it's giving antibiotics before surgery or the blood thinning medication that I'm talking about. So all that preparation may take about an hour and a half, maybe 2 hours. So patients typically will be asked to come to our surgery center at least a couple of hours before their intended or scheduled time for surgery. And of course, it is at that time that they will be meeting the anesthesia staff as well. And the anesthesia staff obviously are the providers that are going to be critical in getting the patient to go to sleep during surgery, because obviously people go under general anesthesia for bariatric surgery, and general anesthesia requires an anesthesia provider to be there, obviously, to help us get the patient safely under anesthesia before the start of the procedure.
So, I think what I'm maybe kind of thinking now, of course, there are exceptions, but then sometimes those exceptions are a little bit more than what we are expecting. Now, I'll tell you what my exception would be. If I have 1 out of 150 patients making a mistake on the instructions, that would be an exception. But if it's 5 out of 150, that's still a decent number of people who have this understanding. So what would be the best way for patients, or what do you think patients are missing for the prep standpoint? Like, hey, was I going to do it, or was I not going to do it, or should I have report this, or should I not have report this? Like, what are they missing for those who are not maybe understanding everything that we are giving them?
So these are important points. Obviously, our instructions not only have to be clear, but they have to be repeated on different occasions. It has been shown, for instance, very often that when patients are given instructions, they may not retain that information on the first go, just because there is the anxiety, there is the mindset that may not be set up to just get that information. So having the information repeated by different components, members of the team, is very important. So for instance, we talk about this, when we see our patients in the office, but then patients talk to the staff in our office, but then they talk to the staff in the surgery center, where the information is always consistent. right? So,
Mhm.
for instance, a very important thing that patients need to know is that they shouldn't have anything to eat or drink after midnight of the day of the procedure. This is an important, uh, piece of information. But then at the same time, what would they do if they have medications that they have to take? If we tell them you cannot have anything to drink or to eat, but then they have to have medication. So we have to be clear in our instructions about what they can take. And on top of that, obviously, patients may have specific medications that we want them to avoid taking. For instance, a good example would be patients who are on metformin. Metformin is an anti-diabetes medication. And typically, we would ask them to hold off on that medication if they take it in the morning, right? Because we don't want their blood sugar to go too far down during the surgery. Another medication that is important for them to understand about it, and also is common with our patients, is a blood pressure medication. Okay?
Right.
Well, we tell them, take your blood pressure medication because, blood pressure tends to go up at the time of stress and anxiety. And if they're preparing for surgery, understandably, their blood pressure is going to go up. So if they take blood pressure medication, the last thing we want them to do is hold off on that medication. We want them to take that medication. Right? So those type of instructions, if they are repeated by different members of the team at different times, obviously the chances are that the patients will retain the information and they follow the information. One of the misunderstandings that comes up sometimes is we ask patients, for instance, to take Tylenol extra strength as part of the preparation to minimize discomfort, and we ask them to take that with a sip of water in their home. But we've had the occasional patient who takes Motrin instead, and now Motrin is one of those medications that we want them to hold off before surgery because they can increase the risk of bleeding. And mistakenly, patients, not understanding the difference between Motrin and Tylenol. Some patients have taken Motrin in the past. So we try to be as clear as possible in our instructions. But as I said, also repeat these instructions from different component members of the team so that patients will retain that information and more are likely to follow it accurately.
Now, between the different surgery types, maybe let's just rephrase the question. Between preparing for bypass versus sleep, are there any differences for the day before?
No difference at all. No difference at all. So patients will be given the same instructions in terms of how they will prepare with their diet, for instance, the 2 weeks before, and the instructions that they will have coming to the surgery center will be exactly the same as well. There's no difference.
Mm-hmm.
So what may be a little bit different in terms of their stay in our surgery center is that the surgery for the gastric bypass may take a little bit long, by much, maybe 15, 20 minutes more, occasionally 30 minutes more than the sleep. That is really the operative time. But the actual time that they will be spending at the surgery center in total will be the same. Patients will come a couple of hours before they have allotted time for surgery. And then we will be talking about post-surgery recovery, but patients will typically stay in our surgery center for 6 hours, sometimes 8 hours. The typical number of hours is really 6 hours. And then what they will be doing right after surgery is very much the same as well in terms of the medications that they will take, in terms of the timing of their level of activity, get up and walk after surgery. Those are the same whether they're having gastric bypass or a gastric sleeve.
All right, good afternoon and welcome back again. Now we are at our Bariatric Friday. We are done with all the boring topics, so the most important one. Well, actually, the first one wasn't boring either. So our Bariatric Friday session, we are going to actually cover weight loss drugs and bariatric surgery. Dr. Irgau is here in our studio. Dr. Irgau, how are you doing?
I'm doing great, Kemal. Thank you for having me again on this wonderful Friday.
Thank you. And as I mentioned, our topic is weight loss drugs and bariatric surgery. And as many people are struggling with these issues, the options for patients or people to have an understanding what these options are is extremely important. With the rise of new medications like Ozempic, Wegovy. Many are wondering how this is changing our approach or how the patient approach is changing, and which one is going to benefit the patient the most, when it should be used, if it's better to use the medication versus if it's better to go with the surgery. Are they actually competing? That's what we are going to discuss today. And so you're going to actually help us with that.
Absolutely. So, like many other disease processes, in medicine, we've very often seen the evolution of treatment modalities. Right? On the one hand, you would have medications. On the other hand, you would have surgery. And both treatment modalities may be appropriate for that disease process. But obviously, one of the things that doctors are good at is try to understand the place of medication versus the place of surgery in that disease process. So similarly, when it comes to the treatment of morbid obesity and its complications, things like type 2 diabetes, high blood pressure, sleep apnea, and so forth, it's not a situation of either or, right? It is very easy from a layperson's point of view to look at medication and say, okay, there are medication now, so no more surgery, or to say, you know what, I don't want medication, I'm just going to go for surgery. See, so those kind of viewpoints where there is almost like a binary type of choice are natural. People are naturally geared to thinking that, but it's important for us as healthcare professionals really educate people that, first of all, these two modalities are not exclusive of each other. Okay, we are extremely happy as physicians who's an interest in the treatment of obesity to know now that we have more than one way of dealing with it. Okay, and obviously there are places where medication is appropriate, and there are places where surgery is appropriate, and there may even be situations where both may be appropriate. So that's really an important way to look at this.
Part of the issue that I see is, and you and I, we talk about this a lot, perception and expectation versus the reality. What's going to happen? Well, there's a treatment option. Well, it's not magic, right? So we always say this, and then so many times, if someone goes back and just runs some of our old videos, they do those collages. So that this would be another one that I say the same thing again and again and again. This is not magic, but the overall public, they really don't understand the level of morbid obesity and what we deal with. So you and I, we do daily case conferences, and the patient that we deal with is not like BMI 26, 27, 28, but minimum of 35 and up, 35 to 40 with different chronic conditions, and 40 and above. We have a patient today who was on the specialist, BMI 82. So now with this patient, the worst thing that we can do is nothing. So there's medication, you use medication. There's surgery, you use surgery. But what's the most impactful is what we need to really understand.
Yes, absolutely. So first of all, let's give some background on what those treatment modalities are, right? So if you look at medications, for instance, there has been clearly an evolution. Until not too long ago, the only medications that were available for weight loss were things like phentermine, which is an appetite suppressant, or something like orlistat, which is a medication that blocked absorption of fat in the intestine. And those medications, in terms of the results that people were seeing, the results were very variable, but they were also very modest, in the big scheme of things. So, the best you could achieve was like a 10% weight loss, which meant that if a person is about 300 pounds and they really need to lose 100, 120 pounds, they would be losing maybe 25 pounds, 30 pounds at best, right? And this is being on those medications constantly. And then, of course, there were other medications like Contrave, which is a combination of an antidepressant and then an opioid antagonist. And those medications were still giving those kind of modest results. And then more recently, we have seen these new classes of medications that were supposed to have been developed for the treatment of diabetes primarily, but then we saw that there were very good results in terms of weight loss as well. These are the so-called GLP-1 receptor agonist medications, and people know them obviously with their brand names, things like Ozempic, Wegovy, and then obviously Mounjaro and Zepbound, which are even more advanced type of medications. And with this, we are seeing some much bigger results in terms of weight loss. And then at best, we could see up to 20% and sometimes even 25% weight loss, which means that a person who is about 300 pounds could expect to lose up to, 60 pounds or 75 pounds, which is really significant, right? So this is a definitely important advancement when it comes to those medications. With weight loss surgery, which has been around a lot longer than this new medications, obviously the results are very, very much more impactful, right? So we would see 30%, 35%, 40% weight loss with this medications, which means that, people could lose, or somebody who's 300 pounds would be losing 100 pounds, 120 pounds over a relatively short period, right? So yes, there is a place for both of them. Now, we have to look at the benefits of medications if you are avoiding surgery, obviously. But with surgery, you're seeing a much prompt result, right? So what is the place? What is the individualization? That is really the key. So if you were faced with somebody who is like a 50-year-old man with a body mass index of 50, who has type 2 diabetes, who has high blood pressure, who has sleep apnea, that person has an really serious healthy issue that needs to be addressed very quickly, right? And addressing that very quickly would be offering something like a sleeve gastrectomy, where the weight loss would be very prompt, it would be fairly drastic, and it would address the medical problems quickly. When you have type 2 diabetes, when you have high blood pressure, and you are at that level of weight, you are at risk of having a heart attack, and you could die anytime. So that serious issue requires really a prompt solutions, and surgery would be more appropriate. So on the other hand, if you're a relatively younger person with a body mass index of 38, perhaps with a recently diagnosed type 2 diabetes, and you're looking maybe to make an improvement by losing 30 pounds or so, then looking into medication and then training that person and getting that person into a good program would make more sense, right? So those would be like extreme examples of where choosing one versus the other may be more appropriate, right? Now, this is a general guidance, right? But then there are situations where, we have to be able to explain the complications as well, right? Obviously, with surgery, and as we've said many times in our Bariatric Friday, bariatric surgery has come up into a level of safety now, which is unprecedented, because we have been routinized so much. We had to prove ourselves beyond many, many limits to show that this was safe surgery, and that helped us really elevate the safety process. And we always say that sleeve gastrectomy, for instance, now is comparable to something like gallbladder surgery or hysterectomy in terms of its safety profile, right? And how about the medications? Well, there are side effects of medication, but one important issue about medications, particularly these relatively new medications, Kemal, is that our experience with them is relatively short in terms of how many years they're having them, right? Whereas with bariatric surgery, we have been doing them for almost 30 years, and we've had hundreds of thousands, if not millions of people who had this surgery over the years throughout the world, so we know what we are getting, right? With the medications, yes, we've seen the potential side effects that can occur over 2 years, but we don't know what the side effects might be if somebody's going to be on them for 4 or 5 years or 10 years, God forbid. So there are these unknowns that have to be taken into consideration. And the reason I'm saying that is because what the trials have shown us, Kemal, is that once people stop these medications, the weight regain is almost so quick. It is amazing. Those people have to be on those medications for that weight loss to persist. Whereas we haven't seen that with surgery. Obviously, surgery, you do it. Yes, there are people who can struggle with some weight regain, but by far the vast majority of people are able to keep a significant amount of weight loss forever. So essentially, again, the main message to be given would be that it should not be an either or, right? It should be individualized. And the greatest news for us in the field is now this is creating awareness among people who never have thought of obesity as a disease, right? You have people who would be walking with a body mass index of 54, and their only concern would have been the fact that they cannot tie their shoelaces or wear something that they want. Health issues related to obesity are coming right up front right now, and it is a great step forward in terms of educating people that obesity is not just about appearance, about quality of life and problems on a daily life, but it's a serious health issue that has to be approached this way.
We understand and we know that morbid obesity is not being treated. I mean, we are never going to fight over which treatment options are going to be better, because we are maybe 100 years away from that point, right? So, because I still have a couple of people just recently reported to me that, hey, I don't want to get into this medication. Well, what do you want to get into? Like, treat the disease. This is not a nose job or a boob job. Like, this is a chronic condition that patient has. So I'm glad from that point that medication is more and more accessible, because it's bringing the awareness of this morbid obesity issue, as now patients are saying that, hey, this drug was available, how come you're not giving me this? Or can I have this? Is this the right thing for me? And we are saying that, yeah, that's a great thing to have.
It is. So it's interesting, right, Kemal, because up to, because of the stigma associated with what causes obesity, and then looking at obesity just as an appearance issue, or looking at obesity as something that is related really to how a person lives or doesn't live. That kind of view of obesity has pervaded for so many years, obviously, right? And up to recently, when people think about weight loss, they would think about, a diet that I can buy, or I can go into Weight Watchers, or I can do Slim Fast. So you're looking at some type of branded, approach that uses food and diet, etc., to help you lose weight. So that was the view we had. When you're talking about medication, the perception changes, because medication is used for a disease generally. You don't take a medication for something that's not a disease. Generally, you take a medication if there is a disease. So when people start opening up to the idea that medication is necessary for obesity, then now we have a different level of discussion, right? Now you don't go to just some diet on a shelf of the supermarket to treat this problem. Now you need medication. So you're looking at it in a different way. That's why, when people ask me, as a bariatric surgeon, do you feel threatened that there are medication? My answer is absolutely not. In fact, I feel gratified that there are medication now, because the awareness of obesity, of a disease, now has gained ground. Similarly now, to your point now, if our providers are going to look at obesity as an issue of individual responsibility, willpower, appearance, then they're going to say, you know what, I don't deal with that. You go to a specialist. But when they look at obesity as the root cause of the patient's diabetes, high blood pressure, sleep apnea, arthritis, infertility, stress urinary incontinence, headaches, heartburn, and all this myriad of problems, then using a medication to tackle it is not only acceptable, but it is imperative, as you say. Before, right, it wasn't even discussed as an issue, right? Now we discuss it. When a patient comes to me, for instance, for a general surgical problem now, let's say a patient comes because they have a hernia or a gallbladder problem, and I see that that person's body mass index is 38 or is 45, I do have to talk about that. I cannot let the patient leave my office just talking about the hernia, because there are implications about obesity and hernia recurrence, right? There are implications about risk of surgery and gallbladder surgery that I'm going to talk. So yes, you don't want to be presenting the problem as if you are judgmental. That is important. So my approach, for instance, to patients when I introduce this, and it's the first time I'm meeting them, and I say, hey, are you comfortable with the weight you are at, right? You ask them that question to just try to understand if patients look at their weight as a problem. And once that discussion opens up, then they give you permission to really talk about it. And then you can educate patients about how important it is for them to lose weight, regardless of the hernia issue that has brought them to us. So it is really a central problem in the health of patients. So the fact that we have medications for us right now, it just gives us an additional tool to address it. And it's great. It gives us an additional avenue to improve awareness of obesity as a disease. So it is a great thing that we have it. And as I said before, as healthcare providers, we are used to looking at different modalities for the treatment of the disease. A classic example, for instance, is cancer, right? We don't say, okay, you have cancer, would you like chemotherapy or surgery? Right? We don't go that way. We say, well, this is this type of cancer. The treatment is best if we start with chemotherapy, we follow it with surgery, or we start with surgery and follow it with chemotherapy because we want to eradicate that problem. And if adding these two modalities is the best way to do it, so be it. And we may have to do that with morbid obesity as well. If somebody comes with a body mass index of 65, it may well be a good idea for us to do medications to bring that weight down a little bit and then do surgery afterwards, right? So that is really the way we want people to be able to approach this issue.